I'll be your moderator today. So let's just overall get a quick overview of what we'll be going through this morning with these gentlemen. First off, we're going to start off with a review of DEI among the CHTs. We call it grip and grasp. Then we'll move on to a brief refresher on upper extremity anatomy and physiology. We'll continue on to some research studies, which each of the CHTs will then provide a short overview of how they would handle that clinical case. And then we'll allow them to talk about the practical approach to the treatment interventions in regards to things. At that point, we'll transition into a Q&A, which will allow the audience to submit questions and ask our panelists just overall questions that they have from the presentation. So what we ask is everyone to drop their questions into the chat when that time comes, or to hold them. And then we'll have someone moderate the chat and feed up to hands that basically call people out. So first thing that we're going to talk about now is we're going to lead into diversity, equity, inclusion. And we're going to look at some data, and we're going to have the panelists talk about that data overall. We're going to also go into just DI and why is it so important in regards to occupational therapy as a whole, but also in the hand therapy realm. All right, gentlemen. So these are the statistics that we have in the background. What would you like to talk about it overall? Feel free, any one of you, to start.
I'll kind of start off. So, I mean, this has been a big topic of discussion, not just in our career field, just across the board, diversity, equity, and inclusion. And until sitting on this panel, and no disrespect to any other ethnicities, but I've been in multiple conferences, continuing education courses, all these things. And this is the first time when I met these guys doing this panel that I ran across not only Black CHTs, but Black male CHTs. And as we all know, some of these things that when it comes to this, I always knew that once I got into practice that I wanted to specialize in hands and eventually become a CHT. And I've worked in the civilian sector in hands, and all of the therapists that I worked for, they weren't CHTs. They didn't even pursue it. So it was just kind of funny, to be in the room. And it's funny to see them now, because I've gone back to and met some of them that kind of trained me, and I worked under them, and they're still not CHT. So it's like that representation. Sometimes if you don't see others do it, you don't pursue it yourself. So it's kind of disheartening. And I think, and we've talked about this offline, I think that we need to start, advertising and getting out there to show, because representation matters. If people see something that they can become, they will seek after that. So I think that that's something that, we need to get after a little bit better, is to, in our profession, to be able to show that, hey, we can do this job too. And I'm not by far a great test taker, but this getting the CHT was probably the most challenging exam I've ever had in my life. And it's been rewarding in the same regard. So, but I'll pass it
on. And I'll step in here to piggyback off what Brother Eric said. To walk into a room and you see only you, it can be a little bit discouraging. It can be a little bit disheartening, but that cannot change what we're doing and the work that we're trying to do. Once again, I said to the Tuskegee University, as far as my knowledge, we've had an OT program for over 40 years, and I'm the only certified hand therapist we have. And that is disheartening, but I also know that will change soon. I have a couple of classmates. I actually have seen a couple of classmates in this chat today that plan on taking the CHT exam, and we are going to continue to push the line and toe the line and do our best to include more Black certified hand therapists, but the demographics show the truth, and that is there aren't many of us. So when you walk into that room, you have to make sure you're 10 times better than everybody else just to fit in. And that isn't always an easy thing, but that's something that you have to do. And you have to know the information because people will question you. And you have to be able to stand strong and know the things that you know and pretty much be able to defend yourself educationally and be able to defend what you know.
Yeah, I would say that the numbers are discouraging because there's only 5% of African American OTs that, it is bothersome, but like both the brothers have said, I think you have to just be willing to do the work. So if you're willing to know exactly what you want, and you're willing to share that information, I think the biggest part, since I've been a therapist for over 20 years, I realized more and more as my career is advancing that I have to do a better job. I mean, I think I've probably had maybe 10 or 12 students as a fieldwork coordinator or educator at this point, and maybe over 20 plus therapists that I've helped mentor over the years. But I think that's the responsibility of every therapist to give back, because the only way you obtain your OT degree is by doing those field works and getting education from someone else. So you have to play it forward, and we have to do it in a meaningful way. That's the way I look at it, is that every day you have to do your best and make time, because it's not easy taking on a field work. Someone comes to, they want to get a field work level 2 from you, and at first you think it's a lot of attention and time, but it's very rewarding at the end of that day when you realize that you helped someone else become a better clinician. So I think all of us could do a better job with that. And I'm going to pass it over to Clyde.
Yep, and then just to add on to that, I think the overall consensus across the board is, for a lot of us on this panel, what we're, I guess, trying to say is this is not a norm. To have 4 Black male hand therapists all here together at once is not normal. A lot of times we walk into different facilities and settings, events, and we're the only person in the room. And that gives us a certain level of responsibility just to show up and represent for not just us, but for the next person coming behind us. We're kind of trying to pioneer and open the doors so that the next tier that comes after us don't have to go through some of the things that we have to go through and having to prove ourselves. I feel like we all have the education and experience required, but we're still day in and day out having to defend ourselves in the field, prove ourselves to our patients. And so I'm just happy to be part of this panel, and to have this representation, I think, is just a start, and taking a step forward in the profession. And it's just, I'm happy for all of us to be here and included and be a part of taking that step forward for us and the tier coming in after us.
But just to add into that too, gentlemen, I think that for me, it's not just our representation of us; it's to our patient population. Because I've been in a lot of clinical settings where, like, the majority of the people being seen is us, and sometimes there's just this thing of cultural knowledge of your patient population, and sometimes some of the other therapists, they don't take into account those kind of things. And being not only a therapist, but being an occupational therapist, bringing that perspective in, because I've worked in practices in a private practice where I work with some PT hand therapists, and their mindset is totally different. It's all data driven, but sometimes as the occupational therapist in the room, you looking at the person and understanding the cultural part of it. Because I've been in, well, we have to go to, or you have someone from a different culture. If you understand that culture, you understand certain things you shouldn't say, certain things you shouldn't do. And even, looking across different practices, like, some people prefer, someone that looks like them or someone that can speak to the things that matter to them. So that's where that representation matters on that front. But then on the other front, I'm pretty sure you guys will nod your head on this one, is like, again, working as a therapist that didn't have the CHT in a hand practice, surgeons will look over you. Like, they don't trust your work. But as soon as you lead with, hey, I'm a CHT, oh, okay, this, that, and the other, it's a different conversation. So I think, and they look at you different. Sometimes I've seen the eyebrows raised when because sometimes I say that just to let the surgeon know, hey, your patient is in good hands. But then the eyebrow, oh, you're a CHT. Oh, okay. Then there's a certain validation that goes with, being able to say that to that surgeon, because, I don't think a lot of people realize this, but a large portion of the exam is written by hand surgeons. So there's a certain credibility that goes with having those three letters.
So this conversation definitely led us into that first question. I think Eric just hit on it about African-American OTs and CHTs impact on patient care, right? So, the other gentleman, how do you think that, for example, this does impact overall patient care? I know Eric's touched on it. What are your thoughts?
I was ready to chime in as soon as he said that. I've had multiple issues come up with diversity in patient care, especially here in Alabama, in the South. You can say that people don't always trust their healthcare providers. And once again, being in the South, there aren't always a lot of healthcare providers that look like me. So I've had multiple patients come in and say, oh man, if you didn't look the way you looked, I wouldn't have came back. I was coming for this first appointment so I could get these exercises and I wouldn't have came back. It's number one. Number two, there's certain things that we know just as Black healthcare professionals that everybody does not know. For example, when we get to talking about my favorite thing to talk about as far as diversity would be how patients scar. In our books, they barely hit on hypertrophic scars and they barely hit on keloid scars. But as a Black man, I know how keloid scars work. And I know that Black patients and Asian patients are going to have a higher chance of having hypertrophic and keloid scars. So we have to start doing scar work on them while sutures are still in. Because if you don't start working those scars at that time, then they will have scars that stick to tendons and they'll cause all number of issues. But if you don't look like us, or if you don't understand our skin, you won't understand how to tackle this. And so this is just a small thing that can mean so much more, because if I have a flexor tendon repair that I don't take care of the scarring, or dear Lord, an extensive tendon repair that I don't take care of the scarring, that entire surgery can be for naught. And that's simply because they have a keloid or hypertrophic scar on the dorsum or the volar portion of their hand. And now their tendon is stuck to the scar. They're in worse shape than they were before. And it's nothing we can do at that point.
Wow. Hey, Chris, I mean, that is so true. Over the years, I've just learned that you have to tackle that head on immediately. And if you address the skin, you can solve a lot of problems. So yeah, I want to just support you in that. Yeah, that is 100% right. Sometimes, I know in our corporate practice, we used to purchase silicone, but it's like most companies, you get away from wanting to purchase things that can be purchased online. but I always find it very useful to have silicone or the use of kinesio tape or other alternatives. I've even I've even gone to Walgreens or CVS, just to see what's available for people in the marketplace, and the silicone that I purchase is thicker than what you would normally get at CVS, because once you use theirs one time, it's one and done, as opposed to the silicone that I purchased. You can wash it, let it dry, and it's usable for 30, 40, 50 days as long as you take care of it. So yeah, I totally agree with that.
And another thing that we can do while we're talking scarring, that you can't get in the store, and my practice kind of pushed against buying it first until they saw the results. Elastomere. So often people forget about good old elastomere.
Mhm.
And elastomere is something you can make that elastomere mold, and that mold can last for 90, 120 days. You just put it on some cold and save it on, and it works. It flattens scars and it helps. So that's just a small thing. We're talking about scarring. Another piece, and then I'll pass it over. But something else that they don't tell us in the books that help with scars is good old remedies that our grandmothers used to use: cocoa butter, shea butter, things that people will not use, like things that no one that doesn't look like us will know to tell a patient to use. Like I'll never forget, I was working with a CHT that did not look like me, and she was having, one of her patients was having an issue with scarring, and I told the patient, "Hey, look, get some shea butter and some cocoa butter, mix the two, moisturize a few times a day, and it'll help." And my coworker says, "I've never read anything about shea butter and cocoa butter," and it was just one of those things where you can't read that, you just got to know it.
Now, that's perfect, Chris, and on the same kind of, but kind of changing it just a little bit, not just the skin, but underlying conditions. I always look at, prior history, and that sort of thing. A huge part of our population, especially in the South, in some places, is, diabetic patients. How do you talk to those? Our patients that smoke, those kind of things that affect their healing as well. I've sat across watching some of our other therapists, do an eval or something of that sort, and don't go into those things, or don't talk on through each session with the patients about how those pre-existing conditions can affect their healing and scarring and those kind of things. So again, that's understanding, hey, there are certain parts of the population that you just can't just deal with the injury. Sometimes you have to deal with the person. And
Yes.
That's the total concept of, again, to me, is what encompasses being an OT, is you're taking that whole person and understanding that person and changing just not this injury, but their entire lifestyle. Because if you want this hand to get better, you want this elbow to get better, you want to recover from the surgery, you're going to have to eat well. Hey, what did you, I ask my patients coming in, for morning sessions, hey, what did you have for breakfast? Are you hydrated today? Make sure you hydrate before and after session. You make sure you take care of your skin. Make sure you do this, so it's the full gambit.
Claude,
just to add on, I'm sorry. Just to add on, looking at the person, I think you also have to look at the cultural impact as well. We know most of us on this panel probably there are different. There are some areas that are well underserved, and in that comes education, of course, and then there's different cultural understandings. So in some cases, I think for us in the Black community, I know for the population that I work with, there are a lot of younger individuals that were influenced by hip hop as well, and there are different dialogue, different languages that they may portray or try to use to communicate that some people may not understand, that we may understand, but that's just the culture that plays a role in that. And when you're looking at the continuum of care, to better understand your patient, there are just certain background you have to have and be able to kind of merge and come meet the patient in the middle, and then add on to that continuum of care, because we just have a different level of understanding of our patient, their background, and where they came from.
Yeah.
Gotcha.
And I would say, I would add, oh, go ahead. I would actually add on to that, Claude, and say that, yeah, I think for me, whether a person is black, white, Asian, or has an alternative lifestyle in terms of their sexuality, I think you do have to meet them where they're at. You know,
Mhm.
even like I think one of us was saying about the language you use with someone, if you say to someone, maybe, a spouse, and not realize that that person may have even though they're female, they may have a female that they call their spouse. So you have to really appreciate where a person's coming from, how they, how they live their life, their financial situation, all that impacts, we're talking about equality, equity, all that impacts what they do in a session. So I know I've had patients that because they were workers' comp and they lost a lot of their income because workers' comp does not pay the same as your regular income. So that being the case, you know, the financial strain, the emotional, the psychological strain that someone may be under plays a part in how they do on that treatment day. So I have to keep that in account when I'm documenting about that patient. I notice sometimes someone else, I've had other colleagues that might write something that could be damaging to someone's case, right? Like, because they may have a case coming up, and because that person may seem to be acting out, that's what I mean. So you're thinking like, well, they seem non-compliant in some way, but maybe you haven't fully understood that that person's having just a bad day, instead of like saying, "Oh, well, that person not." Well, okay, well, what's really going on? Hey, how's your day? Like, you have to really not be afraid to ask the question, because the person you may be the only person that person can talk to. And then sometimes I've actually said, "Hey, no, don't be afraid. If you're really hurting in a bad situation, is workers' comp or whatever it is, don't be afraid to actually go get a third opinion or talk to a psychiatrist about your situation." So we have to be the ones, we stand in the gap where that person they can't talk to the doctor because the doctor's appointment is 15 minutes if they get 15 minutes with the surgeon, right? And then they can't talk to the caseworker because that person really will speak to the lawyer only. So we have to stand in the gap and be an advocate for our patients at all times, I feel. And that's my say on that.
Oh, that's really good information from all of you. And I think it's really important that we have to consider that, right? Different people, different language. It's definitely a great point, Harold, which transitions us into our key piece in this DEI discussion. When we're talking about African-American CHTs, and when we're talking about from an organizational level or an individual level, let's kind of answer both of these questions over the next 2 minutes in regards to it. How can we increase diversity, equity, inclusion for CHTs, as well as maybe, be an individual advocate or promote this within our organizations? Claude, you can start if you'd like, and then we'll just transition to each one of you.
Okay.
Or we can shift
So
to someone else.
in increase in the numbers, I think the best way I think to answer this is, I think OT in general, just to start off with occupational therapy, I think is still developing, and it's still kind of a upward battle, because a lot of people still don't know what OT is, let alone what hand therapy is, which is a specialist of OT. So I personally didn't find out about hand therapy until my junior year of undergrad. And I think I've been taking health science classes since I was a freshman in high school. So the fact that I didn't come across the profession until I was in undergrad, that's pretty late on in life. But luckily, I had the coursework to allow me to go into the direction once I gained an interest in hand therapy. So I think because we're still advocating for the profession, it's kind of like a grassroots movement. So I think you have to kind of start at the bottom, take it all the way down to the school levels. I know, for instance, an example of that is at my graduate school at Howard University, we participate in Backpack Awareness Day. So we're going out and meeting the kids first day, second day of school, and introducing them to occupational therapy through awareness and backpack. But those kids that we meet, they've at least been introduced to occupational therapy. So hopefully down the line, when they come up, when they're asked what is an OT, they know what an OT is. So in that advocacy, I think we have to kind of start at that grassroots level and be able to start young and kind of start to create these pipelines to where you're not having to find out about what OT is late in your academic career or through an injury. You already just kind of have a general idea of what OT is.
You know, I think that, so you go into some of the numbers, 80% of certified hand therapists are OTs, although PTs actually started the CHT career field, if you will. And I think that because the majority of us are OTs, I think we're carrying the bucket for two career fields to a certain degree. We're trying to promote OT while still promoting CHT at the same time. I think it's a terrible burden to kind of carry, but it's a noble one, but still it's a lot to carry. You're trying to promote OT while still promoting CHT at the same time. I honestly don't know the answer for creating, besides just getting out there and stuff like this, events like this, they're showing, because the general public really don't know. I can't tell you how many times I've seen, I'm a therapist everywhere I go. I see somebody out in the street with a splint on. I'm like, hey, what you got there? What's going on? Did you get that from somewhere? Or I see somebody with a counterforce brace or something, hey, what's going on? What's that there? I'm a therapist, and I didn't even know they had those kind of therapists.
Yeah.
Okay, and it's an education thing. I'm always doing it. So I honestly don't. It was funny. A few weeks ago, my father-in-law, he had on a brace, and I'm just like, hey, what's going on with your hand? Why you got this brace on? And he knows what. It's like, oh, okay. It's a constant education thing. Just trying to get out there. So I honestly don't know. This thing has been around for a long time, and we're still trying to promote the field itself, much less us being in it. It's a long road, and I really don't know the answer, but I know that we just have to get out there and just continue to promote, create pipelines, as Claude had mentioned, some kind of way, going back to our schools, promoting, this thing, do our own study sessions, put it out there. I mean, this talk alone generated a lot of buzz. Maybe we can, parlay, push something out of it, create a podcast, something. But I know we can't do nothing.
Well, just to chime in, I think it starts right here with us. I mean, you have 4 Black certified hand therapists. I never thought I would be able to sit down and talk with Black certified hand therapists, let alone 4 Black male certified hand therapists. So it starts with us. I mean, and I can even say it starts and ends with us. This is how we get better. This is how this gets better. It also starts at our HBCU. I looked into the chat a few weeks ago, and I saw an overwhelming amount of Tuskegee University students. And that warms my heart, because this is what it takes. It takes us talking about this, bringing it to them, letting them know that, yes, it's hard, but we can do it. It's hard to walk into the room when you don't see anybody that looks like you. But I want y'all to know, I look like you. I took classes in those same rooms you took classes in. We can do this. This can be done if we put our minds to it. But once again, it starts with us. Like we said earlier, we have to take those students. We have to be happy to take those students, to pass on that information. Because if we don't do it, who else can we count on?
And Harold, would you like to add anything on to that?
Yeah, add something real quick, and somebody had posted in the chat about this too. I mean, it's sad that you have like even some physicians that still write, PT referrals for hand therapy. they just don't write a hand, to a PT. So that's something that I think, going out and looking at some of our doctors and letting them know, hey, we're OTs and we do this work too. As a matter of fact, we're 80% of the population when it comes to hand therapy. So there's a big discussion that needs to happen out there with physicians as well. But I think that just as we've already said before, that we need to, get out there and pub ourselves and make sure that people understand who we are and what we do.
That's a really good point. We got to hit it from the community side as well, hitting it from the physician side. So we make sure that we're getting referred on those things. Definitely a big point. Harold, did you have anything you wanted to add on that specifically?
I think the fellows touched on it really well. I mean, basically, you're on the ground level at schools. I've been a part of going to some of the high schools and talking to students that were juniors or seniors in high school, um, uh, and I think that's an excellent way to at least plant seeds. So in everything you do, you're planting seeds, and like Eric said, if you're in this, even when you're out in the community, you're planting seeds by talking to someone who has a splint on, or, even in my family, they think you're the doctor of everything. So, so I mean, even though you're not a physician for sure, but you seem to somehow have the answer. So yeah, I think this you do it from the schools, you do it from the colleges, you do it from the podcasts or events like this. And is one of my physicians, Fanny Dantalori, who's a great hand surgeon here in Atlanta, says, when I went to him, I said, "Hey, what do you want out of your hand therapist?" When I first met him, I said, "What do you want out of your hand therapist?" And he says, "Access." That was that's the one thing he said. "I want access." And that let me know everything. It was one word, but it meant everything. Basically, whatever he needs on the days when he's in clinic, I give. Doesn't matter what time, doesn't matter when. If he says he needs a splint made for the elbow, for the wrist, the finger, it's done. I don't care how I'm feeling that day, it's got to be completed. And that's my attitude. So it comes down to, like, your attitude has to be clinical excellence, and then you have to have access, not just for your patients, for your doctors, for your coworkers. You just give it all. I look at it like back when I was playing football. You leave it on the court, you leave it on the field, you leave it at the workplace. So when I'm working, I'm grinding, and that's my attitude on that.
That's it. Real quick thing, Harold. Just before we move on, Andre, I
No
saw
problem,
in the
Chris.
chat that Sherry asked the question of, hold on. She said, "Do you think third-party payers too need to understand OT's role in hand therapy?" So Sherry, just let me give you a tidbit of info. They know our role, and they know they have to reimburse us higher than they have to reimburse PTs. So that's why they don't care. If you go back and you look at Medicare a few years ago, Medicare lays the line for pretty much everybody that a few years ago, PT and speech had to share a cap. OT didn't have to share a cap. There's a reason we didn't have to share a cap. They know what's the most important, and they know what will get them the results that they need, but they also know who they have to reimburse at a higher rate. They don't want to have to reimburse at a higher rate, so they don't care. So to answer that question, they know who we are, and that's why they don't like us.
Thank you for that, Chris. So I didn't want to interrupt that rich conversation. I think it was very important to have. But in the spirit of time, what I want to do is there is a video from AOTA about rooted in diversity, where they're trying to, discuss diversity. Feel free to check that out on American Occupational Therapy Association, but we're going to move forward. All right, with that, we're going to lead into now a brief refresher on hand and upper extremity anatomy and physiology from the CHT's perspective. This is not going to be an in-depth conversation just because for the nature of it, they could go on for days and days. I've heard these gentlemen and they got all the knowledge that you would definitely need to hear, but they're going to give us a brief overview so we can get into these clinical case studies and they can tell us our perspective overall of it.
Okay. If you don't mind, I'll start first. This, what you see here, your brachial plexus, this is what's needed to pass any certified hand therapy exam. You need to be able to look at this, dissect this, go from the roots, trunks, divisions, cords, and branches all the way down. This is how the body works. This is how the arm works. This is how the elbow works. This is how the forearm works. This is how the hand works. If you don't have this, you don't have anything. And so what this is, it is your brachial plexus. And your brachial plexus is everything when it comes down to passing the certified hand therapy exam, as well as understanding patients. Because if you can understand this brachial plexus, it makes everything else make sense.
You can just, just go ahead and do the mic drop on that. That's it. I mean, when I studied for this exam, I could trace everything, could know, because on the exam, I mean, it's all, for the most part, it's scenario based. So they'll give you a scenario based on, and you'll know it's like, okay, well, this injury's here. This is at C6. This happens here. This turns into the radial nerve. It's this. I mean, you break it down and it's like, it's that whole thing. I'm breaking down like what the brachial plexus. I actually drew the brachial when they gave you the sheet of paper, the scratch paper. I drew the brachial plexus, and I would say that at least 70% of the exam, I was looking at that drawing and like going through the scenario in my head, and I would come up with the answer in my head and look on the test. It's like, oh, the answer I had in my head is the answer that's right here. This is the answer, and didn't doubt myself. So yeah, you have to know the brachial plexus, not only the nerve, you have to know that run through that. I mean, you have to know it all. So this is the end all be all if you want to practice upper extremity.
Yeah, and just to quickly add, I think the brachial plexus, it's a map, right? So it's a map of the body. So mostly everything can be navigated if you understand the brachial plexus. And when we're looking at the exam, if you want to pass the exam, learning the brachial plexus and understanding the brachial plexus will be your map to passing the exam. So it's just very important. And I think anybody who has an interest in hand therapy should start there, making sure that they understand it.
Yeah, I totally agree with that. Just like Gary, the first thing I did going into the exam was trace out the brachial plexus, and I made that like my priority, like getting that down first, because if you know the nerves and the corresponding muscles, and you understand how the muscles move, you can pretty much you can fare well on a test. So, but it comes down to knowing what you know. So getting that down is one of the most important things about the test, for sure.
Good. Brachial plexus is key. So then we lead into the hand. Who'd like to handle this one?
I'll take that one. Basically, when you want to understand, if you're looking just at the hand itself, you have to understand what each bone is supposed to do in the hand, especially when it comes to the carpal bones. So if you understand the carpal bones and how they articulate to the radius and the ulna, and how each joint is supposed to move in terms of being convex or concave, and the muscles that overlie or are under those muscles, so if they're volar or dorsal, understanding the intrinsic nature of the muscles and the ligament structures that connect bones to bones, and then of course your tendons. So here we can't go in, there's a lot to cover in these areas, but I put these, well, we put these illustrations so that you can get an idea about some of the complex natures of the hand. So anyone else want to speak about the hand there?
And just to add on to that, I think, and I would like to tell all my patients this, yes, we're dealing with the hand, but we know the hand, it starts outside of that. So you have your intrinsic and you have your extrinsic muscle groups. And so you have some muscles that are primarily in the hand that's going to help you more with your fine motor, but we also, in treating hand injuries, we have to go up a little bit further than that, and also not forget about the extrinsic muscle groups, which originate in the forearm. So that's my quick spill on that.
Yeah, and just understanding the corresponding injuries or conditions that go along with understanding all of the tissues and everything. So, and just being able to, I guess, differentiate, between it's this or this, and understanding all of the common injuries or all of the names, and that it's very extensive. I mean, until you've gone into it, you have no idea. I mean, how many different named injuries we have in the hand.
So just to piggyback off of that, we've talked about the bones a decent amount, but as you look to your right and you see all those small muscles, you got lumbricals, you got dorsal and volar and eyesight, you got all kinds of stuff rolling through here, correct? Well, that's once again is why every one of us drew out that brachial plexus before we took this test, because each one of these muscles, each one of these tendons are all fed by something. And if, for example, if I have an ulnar nerve injury at the elbow, I have to know that my dorsal and volar inner eyesight will be affected. Okay, so what do the dorsal and volar inner eyesight do? They abduct and they adduct the fingers. You have to know these things, because if these things, you will know how to fix these things. But it's just so deep. It gets so deep. It's funny. We had this conversation the other day, and literally, you can talk about this for hours on end because it gets that deep. But at the same time, once you get that basic understanding, you too can talk about this for hours on end, because it's not as hard as it seems. You just have to dig into it just a little bit. And once you dig into it a little bit, all these makes sense.
Chris, you're breaking up a little bit there.
Yeah, I would say, just to add on to what Chris was saying, I would say you have to know what normal hand function is, and then also understand what a pathology looks like in the hand. So if he was touching on ulnar nerve, then you have to know what a claudiformity is, and have to understand that, could you use a anti-claw splint to help that patient regain the movement, or how do you strengthen the intrinsic muscles of the hand, whether it's median or ulnar nerve or radial nerve. So that's what I would add on to what he was saying.
Yeah, you're also just going back to the brachial plexus discussion. Some of the things that you'll see on the exam, if you had a cut at this level in the brachial plexus, what hand dysfunction would you anticipate not have? Those are the type of questions that they'll have on the exam. So again, this is where the brachial plexus comes in, but then going all the way down to the hand and understanding, okay, if it's cut here, where does this lead? Where is there, crossover or redundancy or whatever, that you're not going to lose this function or you're going to lose this function. So understanding that is how this all ties back into the hand.
Okay.
Yeah. I think I want to just talk about this one patient I had who like 11-year-old boy who fell back on a glass table and ended up lacerating his radial nerve, ulnar nerve, and partial laceration of the median nerve. And it took about a little over a year, and he had nerve surgeries to repair them, but he ended up doing very well. I mean, so yeah, you have to understand that nerve. Also, you have to understand how the scapula works, because the scapula is posterior to the nerve, and the understand the axillary, and then also the skin. So don't be afraid to, like, if you're a therapist out there and you see something that's very complex, trust me, if you ask the questions, then you can kind of go back and figure it out. But don't be afraid to reach out to other therapists that may have a better understanding of these things, as opposed to just trying it on your own. Just to see if you can do it. You have to really, don't injure a patient because you don't understand. You have to really take some responsibility, because that's pretty serious.
Yeah.
And if you want to reach out to any of us, I think all of our LinkedIn pages have been connected to this PowerPoint. So take those down, reach out to us. Try it. I don't think any of us mind help if you just reach out to us.
That's access. That's access.
It's funny that, okay, moving on to, I guess you were talking about some of the hand traumas. I just wanted to just kind of like, I still remember my first hand patient, and not as a CHT, kind of fresh out of school. And this patient, I think she was changing a light bulb or something at her house, or something that cut her hand pretty bad on the volar side of her hand. Went to the emergency room, and of course, they looked, okay, everything looks good, sewed her back up. So you should be fine, a few days. After about a month or so, her hand healed, but she couldn't move her fingers. No one checked to see if she actually lacerated her tendon. And that's exactly what she did. Lacerated her tendon, but the ER just sewed her back up. And of course, now this time, over a month or two had passed before they even figured it out. So they had to go back in and actually try to find the tendon, which, a ton of scar and everything at this particular point. And it's like, this is my first, I am like intimidated. Like, I am just like, but I always remember that. It's just like understanding this woman could have lost function of her hand, and it was her dominant hand. And that was like traumatizing for me, but it taught me a lot to just make sure that's like, hey, sometimes I'll push back on docs. If I see something that's not right, I get a patient that comes in, it's not, hey, you need to go and this is what you need to look at. This is what's going on. I believe that you have a tendon rupture, or you have this, and sometimes I've directed surgeons a few times. It's like, hey, you need to go back in and do this, or this is a problem. And I love that respect now that as a CHT, I can go back in and I can challenge a doc based on the clinical presentation. Hey, this isn't right. I did this exam, and this is what is coming out. Now, I can't look inside of the hand, but I know based on experience and based on, the clinical presentation that this is a problem. And a vast majority of the time I'm right. And you earn that respect by knowing your stuff, that you can push back like that.
Yeah, just to add on to the clinical presentation, a lot of the patients I treat are workers' comp patients and high traumatic injury patients. So I get a lot of patients that will come in casted, and we all know with the natural function of the hand, it's important how you cast a patient. So surprisingly, a lot of them will come in and they're casted all the way up past the sagittal band level. And we know what that means for the prognosis of the rehab. If that sagittal band is casted in extension, we're gonna have tightness. And if we have that tightness, then we're going to have a bigger problem than the initial injury and why we had them in the cast in the first place. So sometimes we just have to be proactive for our patients. And a lot of times when I get a patient like that, I'll send them right back to the doctor unless there is a specific urgent medical need to cast it. I ask them to bring the cast down because we know for the success of our rehab going forward, when they come out the cast, like we have to protect the natural function of the hand.
Yeah, that's kind of, I've had like surgeons that they want to go in and, remove scar tissue. And usually I like to get those patients on, at a certain time for, it's like, hey, we're just doing some scar, some scar remove. Hey, I need to see that patient the next day. Don't do this on a Friday. Don't do this surgery on a Thursday. Well, I'm gonna get limited time where I can get in there and get aggressive with the patient and get them moving and work on that scar. I'll tell surgeons, hey, you're planning on doing this, get this patient in, if you got some oral time on Tuesday, hopefully you can't, so I can get some decent time with the patient to be able to move them. And I've had surgeons that, like, I told him not to when he did it, and then comes back and the patient isn't moving. I'm like, hey, I told you not to do that. Not to do that. I had this one, I've seen this patient multiple times. It was a softball injury. She dislocated and he had to go in and do some tendon work. And the patient was a smoker, a heavy smoker. Every time she came in, I smelled the smoke on her. I said, hey, you must don't want this to heal, because you're doing a horrible job as a patient right now. I'm one of those tough love kind of, hey, I'm going to tell you like it is. You either like it or you don't, but it is what it is. So, hey, the patient was a serious smoker and she wasn't, doing her part. And then the surgeon just kept wanting to operate. And I'm like, look, man, if you're going to do this next, if you want to give her a fair chance at getting motion, make sure that you don't, because his OR time was usually Tuesday and Thursday. And he just happened to do this surgery on a Thursday before a holiday weekend, which means that we were off on Monday. So by the time that patient came in on Tuesday, it scarred back in. And I told you to advocate for yourself to the surgeon, and I advocated to the surgeon as well. And neither one of them worked. So the outcome is the outcome, which is not going to be a good one. He can send you to another therapist and you're not going to get the outcome you want unless he does it right. And by this time, it was like the third or fourth surgery. Sorry.
Wow. All right. So in regards to the elbow,
piggyback off of what Eric.
Go for it.
Oh, I was going to piggyback. Are we going to go back to those photos that you had up? Because a couple of those were my patients. I wanted to just talk about them really quick. But to piggyback off what Eric said, one more slide, please, Andre. It's a big deal. What people put in, what people put out. My surgeons OR day is Monday and Friday. Anything that's traumatic goes on because they're coming in at their. I love the fact that we work so closely together. Because of that, I feel like we get good results. These are a couple of my patients. I wanted to show some pictures. My first patient is on the left. This is a Dupuytren's contracture, and it was released. It's a palmar fasciotomy there. This is the old school approach. A lot of times now doctors go with Xiaflex, and my doc uses Xiaflex unless you have someone who has a pretty bad contracture like this young man had. And so one quick thing about Dupuytren's, as I think all of the therapists on here, when we were in school, they told us Dupuytren's was something that only white people could get. Well, in the last few years, it's been proven that Black people are getting Dupuytren's. Black people with a history of diabetes are more apt to get Dupuytren's, but also we have to understand where we live. We live in America where we're a melting pot. Literally, we are a melting pot. And we have, we as Black people are getting some of the diseases that we thought only white people could get. And white people are getting some of the diseases that they thought only Black people could get. I have a white patient right now who has lupus. 20 years ago, you could have never told anybody you were going to have a white patient with lupus. So that was a Dupuytren's contracture. Now to your right, you will see one of my favorite patients. This was a lot of fun. This man worked at a meat processing plant. He was cutting meat with a bandsaw, and that bandsaw cut right through the dorsum of his hand. He hit every extensor tendon and got into the joint, and the saw hit the joint of the left small finger here. We got full range of motion. It took 2 surgeries. The second surgery was to release the joint capsule of the left small finger. But when he left me, he was here. He was able to make a full fist, go out completely. He was one of my favorite patients. Now, this patient walked in and he smelled like an ashtray. And I told him, I'm just like, here, yes, stop smoking. If you don't stop smoking, it's not going to heal. Put the cigarettes down that day, and I never smelt him. I never smelt him smelling of cigarette. And just to stop, he got better. He did everything we asked him to do. He would probably hydrate. He was getting sleep in. He was doing what he needed to do to get better. And that helped us. Can we go to our next slide, Andre?
Yes, sir.
And this is the last one of mine. This is on the past spring. I had a guy who owns his own landscaping business, and he was trimming the hedges. Well, somehow he slipped, and the first thing he did was reach out and grab. When he reached out and grabbed, he grabbed the live, clippers. And if you see here, he clipped pretty much completely through the index finger. He got the flexor tendons of the ring finger and ring finger. I'm sorry, finger and ring finger, and he nicked the small finger. He was zone 2 of all, which is considered no man's land, but that's another discussion. But he didn't get full flexion back, but he got here. He was able to curl the ring finger, small finger, and he had an FDS finger of the index and middle, which in this case is a success. That's a success. So at first we thought he was going to lose that index finger. So for him to keep all his fingers and the ability to hold again and do different things, it's great. He turned out great.
Nah, that's cool stuff, man. I've had some really crazy cases I've seen. Most of them were in fellowship up in Philly. I had a guy that had a full replant, which you really don't see much these days. But because he was a prisoner, they weren't going to spend much time on fixing his hand. But from that, we had a huge talk about robotics. That's the main thing right now. So once you have the hands cut off, there's no more replanting and you can't do flexors and extensors at the same time. So you what are you going to work on? What's going to be your priority? So that's pretty much a dead hand. And then you talking about no man's land. I've seen a whole lot of talk about there's no such thing as that anymore. So it's that would be an interesting, like you said, that would be a really interesting discussion that you can just do on your own. Actually, a lot of this stuff, you can just have a separate talk on all of this on its own, because there's so much back and forth and so much new stuff that's out there when it comes to rehab and certain things. So it's fascinating, the hand itself. And that's what drew me to this profession, because it's just so fascinating. There's just so many. Every year there's something new that comes out. Just like you said, the Zyplex. I mean, seeing that, and it is such a crude practice to just do the injection and to come in, crack. All right, see you tomorrow. It's pretty interesting practice. So, good fun stuff.
So it leads us to the elbow. Gentlemen, what are your thoughts on that? Eric, you're on mute.
I love the elbow, and we can probably have a long discussion on what's the most important joint in the hand, and I'll tell you it's the elbow. Because without the elbow, you can't use your hand. You can't bring your hand to your face, you can't feed yourself, and you can't take care of yourself. So the elbow is one of the most important joints to me, and I love working on the elbow, dealing with everything from the different swellings and I know we had on our offline discussions, we had so much talk about like, you know, we talked about lateral epicondylitis. Hey, you know, earlier research, let's burn it out, you know, let's do this. And then talking about, you know, I hate counterforce braces. I don't know what you guys' thoughts on that is, but
I second that.
Yeah, I don't like them either.
Counterforce, we could talk about orthotics and everything when it comes to the elbow. I hate mobilizing the elbow because a stiff elbow is, man, you're going to have to put in some work to get this thing to straighten out. So I had to bring my hard hat when you're dealing with a stiff elbow that's past any kind of, hey, if you don't have any limitations at this point, hey, we can go for broke and we're going to go to work on this elbow. So I hate stiff elbows. Well, I mean, stiff elbows are fun because you get to get in and you can get grimy with some elbows. So,
Yeah, I try to tell the doctors to send me the elbows as quickly as possible. So if you get an elbow after having a fracture and having an internal fixation, if you get the elbow to me within 2 to 3 weeks, and then start working on the edema, getting some soft tissue work on the biceps, making sure that those flexors and pronator muscles are soft and mobile, and then of course addressing the scar. Then I think you'll get a better outcome. But I had one patient recently who had a fracture, and the fracture was a year old. And so the doctor said, "Hey, you know, this patient was being seen by another clinic. Would you mind taking a look at it?" I said, "No problem." Guy comes in after a year, he's at 85 degrees of flexion. I'm like, wait a minute, 85 degrees of flexion. Come to find out that the therapist where he was at before, when he was getting stiff, did not order a static progressive brace for him, like, you know, like Lance Medical or Dynasplint or anything like that. You know, when you see someone getting stiff, you know, you can't hesitate. You just gotta go for it. And you gotta explain to the patient how important it is that the financial cost of not getting the brace is worse than you spending the money. So yes, you're in therapy, but I need you to have extra help when you're not here with me. So I think I'm going to discharge this man in about another week, and he's at about 125. So you know that uh, functional range of motion for elbow is 30 to 130. So hey, for me to get him to about 120, and he was stuck for, you know, at that point for a year, to me, like, that's success right there. So
That is success. One thing I would like to say, oh, perfect, right there on that Radiohead replacement. One thing I would like to say as far as our patients, 2 points. Radioheads and those patients with those elbow replacements. So often, you'll see in clinics, PTs and some OTs like to put their elbows lay them on the table and kind of crank on them. If you can, just my tidbit, if you can, try to stay away from the table. The table is a traumatic experience for patients. They feel helpless. It's pretty much one of those things where they're laying on their back and you're cranking on their elbow. They feel helpless, and a lot of times they won't come back because nobody wants to feel as if they're laying down and being tortured. And so you try your best to keep them in a seated position, and you move the elbow around as you can from a seated position. If you have to lay them down, make that your last ditch effort. Make that the last thing you want to do. Because laying patients down, they feel just lost. They feel like they have ability to do the things that they want to do, and it can be debilitating for the patient. Second, Eric hit on this earlier, and that was lateral epicondylitis versus lateral epicondylosis. That's a big talk, and it's a big talking point for me. I've had this discussion with many therapists, and The years of let's burn this out, we got to make these patients work so that the tendon feels better, that doesn't do it. When you start looking at lateral epicondylitis or lateral epicondylosis, most of your issue is at the extensor tendons, which would be the mobile wide of Henry that sits right here on the dorsum of the elbow and right on the forearm. The thing is, and I put it to people like this: when you think of an angry muscle, what color do you see? And most people say red. Okay, so when you get in the car and it's hot, what color do you turn the thermostat to? Do you turn it to blue or to red? Or I said, well, you turn it to blue. I said, it's the same thing for a muscle. If you're thinking red when you think of an angry muscle, why would you put more red on it? Why would you make them do more exercise and make them do more things that will make it hurt worse? Their day-to-day life is what got them tennis elbow or what got them lateral epicondylosis. So how about we do some things to make them feel better while in therapy? Once we get them pain-free, then we can strengthen those muscles back. But if they're not pain-free, they're not gonna get better. Funny story done. I had a guy tell me, he said, oh, Chris, my tennis elbow patients only need about 3 visits and they don't even come back. They tell me they feel great afterwards. I was like, yeah, they don't come back because they don't get better. You're not going to come up here and work somebody to death with a bad elbow and think that they just going to keep coming. Like, and I asked the guy, I said, so how often do they call you and tell you, oh, I feel better, they're discharged? He said, no, they just stop coming because they feel better. I was like, oh, okay, that's perfect.
So for the elbow, Chris, you made a great point that when you range the elbow, it can be a traumatic experience for the patient. But my treatment approach is a little bit different. This X-ray here is for one of the patients that I treated, and I like to lay them down on the table. But before I go right to the elbow, I kind of prepare them for the range of motion activity. So a lot of times I'll lay them down, use some heat, give them a heat stretch, and then allow the muscles to just relax from the heat alone. And a lot of the patients, when the elbow is stiff, the heat is relaxing to them. And we also know most elbow patients, anytime there's a stiff elbow, is the elbow is not the only thing that's going to be affected. A lot of times when you have a stiff elbow, you're going to end up probably having a stiff shoulder as well. So a lot of times when you have a stiff elbow, patients kind of have a tendency to guard and bring that shoulder in. So usually when I get a patient that has a stiff elbow, my evaluation starts as soon as I see them walking to the clinic. Are they guarded? Is that shoulder in? Is it a natural gait movement? So when I lay them on the table, I actually start with shoulder modes. I'll do some shoulder modes, relax them, have the patient on their side, and then I'll lay them down. And then when I do the elbow stretch, I talk to the patient throughout the treatment. So a lot of times I'll, explain ahead of time what I'm going to do, but also let them know the treatment is not meant to be, I believe in stress and relax technique. So I'll take them up to the point of stress. And as soon as they feel it, I'm not going to push past that stress. I'm going to allow the patient, give them some time to relax while I apply that treatment. I'll talk to the patient, and hopefully they're kind of focused on talking to me and start to relax them. And then I'll continue and add some more stretching techniques to that patient. The X-ray the reason why I put the X-ray on there was that patient had a radial head arthroplasty, and he did develop a stiff elbow, but he started therapy late. So because he started therapy late, it was very hard to get his range of motion back. And ultimately what happened, I ended up treating the patient for quite some time, but ultimately what happened was the physician had to go back in and remove that radial head. He had high pain reflex as well. So his body just really didn't take on to the implant. So that was my first time actually seeing the actual arthroplasty. So the patient came back into treatment and brought in the actual arthroplasty, and it was, to my surprise, that was not what I expected it to look like. You can see what it looks like on the X-ray. I thought it would be a little bit bigger, but I just thought it would be cool for the audience to see like what an actual implant or arthroplasty looks like. But to give you an update on that patient, once that arthroplasty was removed, we were able to gain some more range of motion. I think I'm still treating this patient. So right now we're at about 120 degrees of flexion. And we're not quite at 30. I think we're only gonna be able to get them to maybe 30 degrees of extension, which is still a functional range. We know functional range of motion for the elbow is 0 to 30 degrees. So if I can get him to that 30 degrees, I know he'll, be able to do most of his ADLs. And I'd like that 120 to at least get a little to 130, but with that 120, he's still able to, he wears a ponytail, so he's still able to do his hair. That's one thing he always says when he comes into therapy, like, hey, I'm able to do my hair. I'm able to reach over to the opposite ear. So yeah, so I thought that would be a cool case study for the audience to see.
Yeah, I think sometimes we get so wrapped up into the numbers. Sometimes it's like, yeah, 30 to 130 is the functional range. But if somebody is good with 40, if they can do everything they need to do and at 40, not that I'm not going to work still towards that number. I'm not going to be so focused on the number versus the function. Because one of the first things I do in an exam is like figure out who the patient is and what do they need to get back to. Because if you're focused on, that number, that's your goal. That's not theirs. So understanding what they need to get back to is the most important thing to me, and not so focused on the number. Because once I hit that goal, then I'm moving on to the next, but still working on that number because I know the more that number is, the better they'll be. But I'm not gonna make that number my be all goal for the patient. But then the other part, like Chris has said something, and to some degree, I agree, but where I disagree is I like to lay the patient down because a lot of the times they are more comfortable laying down than sitting up at a table, which is where most of us will sit up at. And I like to use PNF. PNF techniques work great with the elbow because then they're using their own mechanical function. But just as Claudette mentioned too, the shoulder is often involved with the elbow. And if we just talked about the brachial plexus, you understand that the less they move, the more those nerves sometimes can get scarred into the tissue and they shorten. And then you're dealing with a whole nother issue. So understanding how important total, upper quadrant movement is for the patient. So I like to get them moving, that whole upper quadrant, just getting them moving, getting them into activities, because you don't want those nerves to get scarred in or get frozen shoulder or some of these other things. So I use a lot of different techniques. I like when it comes to an elbow patient, I consider that hey, I'm gonna need a whole hour for this patient because we're gonna be working on so much, just getting that movement going, because you don't want those nerves to get scarred in. You don't want them to shorten because then they're gonna, it's just funny. Patients will tell you what's going on. You just have to listen and understand. Hey, when I do this, I get this. Oh, well, it's the elbow. So that shouldn't be, we're working on the elbow. So we really need to get into the practice of understanding and tying in that whole piece to everything because everything is together. Everything works together.
Which leads us into the shoulder. I know we touched on this with the brachial plexus, but do we need any muscular level that we want to talk about this? In regards to the shoulder, or do we want to proceed?
Before we go into that,
sure.
Real quick, just one thing, like they were saying, that's what makes us different from PTs, and that's what makes us OTs. We focus on that occupation. The number matters, yeah, it matters, but nothing matters more than the occupation, the ADL, the ability to do the things that the patient wants to do. Why stare off their back in the shower, after the shower? All those things play in more than just the numbers.
All right. So we talked about the shoulder. We've talked about the shoulder brachial plexus. Is there anything you want to add about that and dermatomes in regards to it, or do we kind of hit on that enough?
Let's go back just a little bit.
Sure.
When talking about like the elbow, the shoulder, hand, make sure that, I think it's important to rule out the neck. That, we all learn about, Sperling's test, making sure that if there's anything, you could have true tennis elbow, or but if it could be coming out of the shoulder, so it should be coming out of the neck, I mean. So make sure you assess the neck to do the Sperling's test and see if there's any nerve root involvement, that could be coming out. And because you'll see that radiating off the deltoid or down the infraspinatus, down the arm to the elbow. So you could have someone that with overlapping pain patterns. So that's important. Yeah, I think the shoulder, as far as I'm concerned, if you once you become more advanced as a therapist, understanding how to unlock a frozen shoulder, very important. Understanding how the nerves play a part in that, how to do those shoulder glides, those scapular glides, very important. So that's what I would add to that. And not be afraid. I think there are a lot of clinics where um, other disciplines want to kind of take the horns and say, okay, well, we do just shoulders. We do the shoulders, and then no disrespect to anybody, but I think that I'm just as good doing the shoulder as anybody else. So I'll say, hey, physician, send me the shoulders. Don't be afraid to send me your rotator cuff repairs, labral tears, whatever it is. I'm not afraid to go in there and represent myself doing that. So let's hear what the other guys have to say about this.
Yeah, I we've had a heated discussion. I've worked in co-practice with PTs for a while, and we've had a heated discussion over whether or not OTs should see shoulders. And finally, they articulated what their reason, and I still don't see the legitimacy in it. But and then I've known some OTs that have not, just as Harold had mentioned, if you don't rule out the neck, and that's where they said they drew the line at most of the OTs that did shoulders. There was no cervical assessment of if the neck was involved at all. So I say if you are going to take on shoulders, make sure that you understand that complex and how to do those kind of assessments to make sure that you're not involving, or the shoulder or the neck isn't involved. But that just, again, sometimes that just takes a more mature therapist to kind of understand your lane and your limitations. Everything should be done, especially if you don't have that expertise. Hey, consult with the PT. Hey, hey, can you show me, just to make sure that you understand that area and know how to do those exams and what those exams mean. And what should you do coming out of that? If it's positive, if it's negative, maybe negative now. Are you assessing it during every treatment? Just to make sure. And understanding false positives too. So I think that there's just something to pass on.
With that, we're going to now move on to our research and case study time. And we'll lead off with, I believe Harold is first.
Okay. The first case study, the association between upper extremity dysfunction and sleep disturbance in the elderly population, included 159 participants. 56 were men and 103 were women. Basically, they used different criteria: the quick dash, the Athens insomnia scale, the Euro 5 dimension 3-level scale. That's basically lifestyle scale. And then they also measured bilateral grip dynamometer testing. The main conclusion of the study was that people who have shoulder dysfunction don't sleep well. And I find that to be true in my clinical setting as well, is that if you have someone that will come in with carpal tunnel or some kind of nerve compression syndrome, they'll tell you that, hey, I can't get a good night's sleep. And I think you have to be willing to go back to that last slide where we were talking about the shoulder, is that if you can figure out what's going on at the shoulder and you can get someone to sleep better, then you can get a more uh, accommodating patient, because the overall goal is to get that patient to participate in therapy to make their function better, to get them functionally independent. And if it means that you're addressing the shoulder to unlock the hand or the elbow, then I think that's what you got to, that's what you do. And so that's the main gist of the study. They I would say that out of the results, they found that 28.3% of people out of that 159 actually had sleep disturbance due to the shoulder dysfunction. And that's what I would say about the study. Anyone else want to add anything about sleep disturbance in their patients?
Sleep is the all and be all. As I did a lot of my doctoral research about how sleep and the importance of sleep and how it aids recovery. So it's sleep is the end all be all. If you're not sleeping well, you're not recovering well. You're not recovering well, you're just not going to be available a lot of times, not only mentally but physically for rehab. So and we already know from the sleep research, as you age, you sleep less anyway. So that's just one of those things that you just have to kind of pay attention to, just making sure. And in an older population, if they're not getting a full night's of sleep during the night, then sometimes they have to get naps and that sort of stuff. So you encourage that a little bit, because sleep is where your recovery is coming from. So it's spot on from my perspective, not only in the older population, but everyone. I'll talk to, if you look at some of the studies, kids with behavioral problems, guess what? They're not sleeping well. Anybody who's not healing well or having any kind of issues, they're not sleeping well. So you especially want to encourage people that are dealing with any kind of injury to get proper sleep.
Okay. We'll move on to our next study.
All right, this was my study, inclusion and perception of hand therapy content in occupational therapy programs. So this study was mostly focusing on how we can get hand therapy taught more into OT programs so that we can have a future for our OT students in hand therapy and our future OTs in hand therapy. I was blessed at Tuskegee University. We had our program director was big into hands, so she kind of fostered that process of to be and talking about hands. And so it's one of those things where throughout the study it showed that most programs get a week combined on hand your entire OT program, and that's just not enough. That's not enough to dig into how deeply we need OTs in hand therapy, and also on how much hands can help you pass. Just that understanding can help you pass the NBCO2 and many other things. But I think the gist of the study was the fear of OTs inside the CHT credential. Like it was stated earlier, it seems like we're bearing the burden of carrying two professions, OT and CHT. And so the fear is that we lose the moniker of CHT to possibly PT simply because we don't have enough undergraduates going into it. I'm sorry, not undergraduates that's going into it. And the next, I think the study said 10 years, projecting that between 2,000 and 3,000 CHT retire. Well, there's only right at 6,800 of them in the United States. We lose 2,000 to 3,000. We're going to be in a rough place. That's why it's so needed that students learn, decide to go into therapy. Does anybody else have anything?
Okay, we'll move on to the next study then. Dr. Eric, you're up.
So this was mine. Just bottom line on this one is just you deal with a lot of infections when you're dealing with people who are using intravenous drug use. So that's just the bottom line up front. So you have to just be cognizant of, you know, different types of signs and symptoms of infection, cellulitis, and that sort of thing. I've seen, not personally, I really haven't had a lot of intravenous drug use type patients. But just infections alone, just understanding how that could just compromise or just change your whole treatment plan is just extraordinary. And even still as a CHT, that's still kind of, I want to say those are the kind of things that kind of keep you up at night, because there's just so many things that can happen when you have those type of infections, and your treatment plan just goes all the way out the window. In a sense, you're not worried about motion, you're worried about controlling the infection and working with the, you know, your whole treatment team, your physicians and that sort of stuff. So I've seen, again, not just with drug use, but just, you know, abscesses and cellulitis and how that stuff could just, you know, go south really bad for a patient. So you want to understand again and understand those symptoms and know how to respond to that. So again, that intimidates me. And I wouldn't say I'm seasoned, but I don't, by means, I'm not the OG Harold. Been around for a long time, just seeing all of these things. So those things, I would say they definitely still intimidate me. So.
Okay. Anyone would like to add anything on this particular study?
No, I think Dr. Spike did a great job.
Okay. All right, Claude, you're up.
All right. The reason why I chose this study is I think with CRPS, I think it's for me personally, I think it's one of the more challenging diagnosis that we would treat, and a lot of the times where it's often misdiagnosed or caught later on in the episode. And one of the reasons for that is it's often a secondary injury. We know with type 1 CRPS, that's usually bony related, soft tissue related. And with type 2, that's usually nerve injury related. So with type 1, it's probably the one I see most frequently. A lot of times those are the patients that come in and they're casted for a long time. I see it a lot of times with TFCC injuries. I think I associate that to the extra dressing and cast that they have to stay in until they come out of that. But why I think it's important is because the clinical diagnosis is usually what determines CRPS. You may see MRIs or CAT scans used, but the ultimate diagnosis for it is the clinical presentation. And often when we treat our patients are with us more than they are with the doctors. They may follow up with a doctor once a month, but the patients are coming to us 2 to 3 times a week sometimes. So it's important to be able to figure out what some of those possible mechanisms may be. So when you have somebody coming off an injury like a TFCC, that should always be kind of in the back of your mind is when you start having that pain response to be able to identify and check off some boxes. So the best approach is the or criteria that is used is the Budapest criteria, and I think that's 4 different categories. We have I think it's vasomotor, I believe it's sensory, vasomotor, sudomotor, and trophic changes. So to be able to check off the boxes, I think if you demonstrate 3 symptoms in that category and 2 physical signs of that category, then you're considered to have CRPS. So once that's identified, it's important in how you treat it. A lot of times with pain, therapists will have the tendency to treat it, with modalities or to try and desensitize the area. And with CRPS, those type of treatments will not be successful. But the only way to be successful in treating is making sure you diagnose it correctly. So we know certain things with CRPS, that patient's probably gonna need a lot of education as to what CRPS is. And it's a little different treatment because you have a person that has hypersensitivity to pain, but the best course of treatment from my experience is the stress loading approach. So someone that has a heightened level of pain, we're actually going to ask them to do more. We're going to ask them to at least go through 3 different changes where they're carrying or ringing or scrubbing. And those are kind of intense activities. So if you have somebody that's in a heightened level of pain, like having the ability to explain to them like, hey, I know you're in pain, but I'm going to ask you to do a little bit more. And ultimately the response is to kind of train the body to realize that activity is not as noxious as they perceive it. And that also at some point will probably need some psychological help as well. So it's not uncommon to refer those patients to a psychologist as well, because when we're as OTs, like we mentioned, like we have to look at the person as a whole. And a lot of times with CRPS, it is a sudden onset. And anytime you have a traumatic experience like that, there is a psychological component. You have a patient that probably was really active, and to the point where with an injury like CRPS, something as light as a shirt touching their arm might be stimuli, right? I think that's called allodynia. So something that light can cause pain. So I think that's why this was a good piece, and it'll definitely be a test question for anybody in the audience that's interested in taking the test, just being able to identify some of those things.
Thank you, Claude.
Spot on, Claude.
So we're going to transition into the practical approach treatment interventions for each of our panelists now. I guess, Chris, if you would like to start us off, or we can go off the order of Dr. Spite. It's up to you.
I'll start us off. I think for the practical approach, I think we've all talked about different cases at this point. And as time winds down, I want to make sure we leave the floor open for questions. But my practical approach is always client-based and occupation-centered. I want to make sure that, number one, the client patient is making sure we're meeting the needs that they have. Number one, I don't care if they're a work comp patient, a Medicare patient, whoever they are, their needs come first, and then what they want first, and then the occupation. So we got to make sure we treat the whole person. Make sure we treat them mind, body, and sometimes spirit. We have to treat the entire patient, and we have to help the patient the best that we can. My treatment approach is always the same. Try to do it pain-free. We try to do most of our treatments pain-free. We never to leave thinking this was a traumatic experience, number one. And number two, I think that whole statement of no pain, no gain is one of the worst monikers we can have as far as therapists, because the no pain, no gain will make your patients not come back. And then they never gain because they never get the chance to get better, because once again, it becomes traumatic.
Okay. Dr. Spite, would you like to go next?
First of all, y'all gonna stop disrespecting my name. It's Spate.
Dr. Spate. Apologies, Dr. Spate.
I'm kidding. I echo what Chris said. I look at my patient and who they are, get to know what is important to them. Because if you don't reach them that way, you're gonna lose them. And I want them engaged. I want them active. I want them excited about getting better. And if they're not intrinsically motivated to get better, you're not going to get them better. So, and that's why I enjoy working in a military setting. I hated working for people who were kind of, some of the workman's comp people who didn't, when I was in private practice, who didn't want to get better. They was just coming to just check the box or some of those kind of things, or sometimes, you know, Medicare rules force you to see people a certain number of times and this sort of stuff. Or I hated when I had patients that, you know, limited their number of sessions, you know, and you have to like pick and choose. Well, they had a previous injury and they are only allowed 60 visits a year. And because of their previous stuff they had going, they have 10 visits left. And I can't get them better in 10 visits. I can't improve their function in 10 visits. So how do I adjust this to what they have so that they could still get better and, you know, not be held to those. So again, it just goes back to knowing what is important to the patient, what other complications we're having to deal with, and getting them involved in their treatment. I'm big on, I learned this in fellowship, one of the doctors, he would always like he'd draw out the hand and say, this is what your hand looks like, and this is what's wrong, and this is what we have to do. And I got in a habit of doing that, drawing out or using diagrams or using models. It's like, hey, this is your hand. So they can see, they can visualize. I'm a visual learner. So I know a lot of educators will say there's no such thing, but I learn better when I can see something, I can touch something, and I can visualize it. So I try to give that to my patients too. So I am all about the patient, no one size fit all. I may have a protocol of where certain things work, but it's based on the patient. You know, I have so many different tools and modalities that I use cupping, I use dry needling, I, you know, use a lot of different manual techniques, active release technique, you know, everything. I have all these things at my disposal, but I don't throw everything I don't throw spaghetti at the wall and see what sticks. I see, hey, does this patient have a very high pain tolerance? Can they tolerate these things? If not, I won't use that. You know, if they have a good pain tolerance, maybe I can use a more aggressive techniques if aggression is what's needed. You know, so I adapt to the patient. You know, it's a constantly evolving treatment with the same goal of getting them better. So that's kind of my treatment approach.
Thank you, Dr. Spade. Next up, Harold or Claude?
Yeah, I'll take it. As far as philosophy, I just patient walks in the door, you know, I look at how they're walking, their posture, um, try to assess exactly what's going on from them from a personal standpoint. Give them some space so they can actually speak, and then listen to what they tell me, because patients will tell you like how they're feeling or what's wrong or where it hurts, or what discomfort they have. Sometimes it looks obvious, but once you actually listen to them, especially if it's like non-surgical, you know, if it's you know, some other like nerve compression, but they're saying they have pain and it seems like in an odd area. So, you know, the referral may say carpal tunnel, but then you're like, yeah, but most of your pain is like on your mobile wad, like it's back on your elbow, and the doctor puts in there like that it's you know, lateral condylitis, but then you're like, no, this is radial tunnel, you know, and you're like, wait. You're like, okay. So you have to like be willing to truly assess. And too oftentimes I find that people will just you know, oh, it's the hand. Well, we're just going to work on just fine motor stuff. Well, no, you have to like really look at the patient and talk to them and figure out and really be willing to, you know, I mean, I look at quadrants on the hand in terms of evaluation. So I might start on the dorsal radial side and then the ulnar dorsal side, and then I'll progress to the baller side of the hand, looking for swelling, scars, anything that seems abnormal based on what kinesthetically what should be functioning normally, right? So you know how a hand should function, how there should be a natural cascaded movement of the hands into a fist, and how they should extend properly, and how the forearm should move and the elbow should move. And so you look at all those things and take them into account to make your assessment, and then based off that, then you progress to your treatment goals. And so, like I think Chris said, you try your best not to cause pain, but in my mind, as someone before I became a therapist, my mindset was possibly becoming engineer. So I always think, if something takes energy to break, like a broken bone, I tell patients straight up, hey, it took a certain amount of energy to cause this uh, damage to your body. Well, what you got to put back into is going to be equally as much. You've got to be willing to put the energy in terms of effort. And so that's my philosophy, is that, if you're injured, you got to do the home program. I'm going to be asking you about if you're doing it. And if you're not doing it, then you can't have an expectation that doesn't match your effort. That's what I want. And to do that, I'm your biggest advocate. I'm your cheerleader, I'm your football coach or your basketball coach. I'm whatever you need to help you get that goal. So that's my philosophy on that.
Okay.
That's why he's the OG.
And Claude?
Okay. So my approach, I love that this question is on there, because I think it's a fundamental piece for anyone who's starting out or has an interest in hand therapy, and just having kind of a direction or guide to how to treat and manage their patients. For example, I work in an outpatient clinic, and a lot of times we'll get referrals that are very vague, and sometimes it's not easy to get direct access to the doctor right away. So you still have the patient there, you still have to provide meaningful treatment. And I think that having a practical approach is important. And I actually thank my professors at Howard, because that's something that was always drilled into us, was that we have to have a frame of reference and a reason for doing what we're doing. So one of my favorites are the biomechanical approach, and that's really a bottom-up approach. So I think you guys hit on a lot of the aspects to that bottom-up approach, where you're looking at prerequisite skills that make up the overall goal for the patient. So it's a client-centered approach. So when that patient comes in, you're gonna look at all the components that make up the activity. So if it's the range of motion, if it's the soft tissues, edema, a limiting factor. And once you identify those different components, how can we do our best to manage, build those components up, meet our goals to get to the overall goal of treatment. So for anyone who is just starting out, I recommend just taking a look at the biomechanical approach.
Thank you, Claude. All right, so we're gonna move into the elephant in the room, which is the CHT exam. Just so we can make sure we address some Q&A questions, could you, each one of you, just give us one tip that you would say is very key? I know the brachial plexus, you talked about that, and you said that is a key piece for the CHT exam. But is there anything else you'd like to just give the audience a tidbit of what would be something that's really key?
I would say just you have to understand the blueprint of the exam, and part of the exam too is splinting, and it would be hard pressed for anybody to just sit and study for this exam. I think a lot of this exam comes from practical experience. This is not one of those exams that there's just a book you can just go read and take the exam and pass the exam. This is practical experience. It's in the clinic. So my recommendation for anybody who wants to go pass the exam is to go find them a hand surgeon and spend time with a hand surgeon, understanding what do they look for, their exams, looking at radiographs, looking at diagnosis, differential diagnosis, all those things. You can study to your heart's intent, extent. But if you don't have that practical experience, it's going to be difficult. Not that it's impossible, it's not insurmountable, but I think that you really have to spend the time with the hand surgeon. You really do, if you want to have the best experience. And everybody's probably going to have their, but the time that I spent in clinic with the hand surgeon, in the OR with the hand surgeon, was just invaluable. So that's my strategy I would recommend. And if you don't have that, then, if you're studying, like I said, spend the time focused on the things that you know the least about. If the brachial plexus is your weakness and you know all the other stuff, then spend your time on the brachial plexus. It will be well served. I mean, we foot stomp that throughout this this panel discussion, but I don't think it can be understated how important that is.
I definitely agree that finding and building a relationship with a hand surgeon can definitely help. I also think I've never met a hand therapist that didn't love doing what they do. So if you could just have some mentorship with somebody who's been there, who's been in your shoes and taking the exam and still practicing, I think is a great piece. So usually if you reach out to a hand therapist, most therapists like love it because one, it keeps us engaged, it keeps us fresh. And also we've been in your steps, your shoes, and we understand the steps needed to get there. So I think that mentorship is a good piece and building block to preparing for the test. Also, one of the things that I did, it's a little pricier, but if you have the opportunity to do it, if you have a hard time having dialogue with a physician, because a lot of times their schedules are busy. So if you're not in a physician ran facility, it's hard to really get a few minutes with those physicians. So the Philadelphia Hand Symposium is a great way to do that because that's where hand therapists, some physical therapists, and then hand surgeons all come together for this conference. And basically it's a 3-day course, and you're engaged, you're seeing what the physician perspective is, you're seeing different therapists who've been practicing longer, some who may be in the same shoes as you and preparing for the exam, but you get kind of like that fellowship when you go to those type of events. And I even got to the point where I think like part of the symposium were actually going through and seeing all the hardware that they use for their surgeries. I would have never got that experience had I not gone to that symposium. So I think that's like a great way for anybody who has a chance to go to that symposium.
Harold or Chris, any tips?
Yeah, I'll go next. I think you should, go ahead and take the practical exam. Well, let me go backwards. I think Eric made a good point. If you can get with a surgeon, it's definitely a great idea. The wealth of knowledge you get from being around surgeons, their mannerisms, how they process information is very clear and concise how they derive at a conclusion for patients, how they do their assessment. So I think being around surgeons is by far one of the best things you can do. Now that's hard because of surgeons' time limits. So then, like Claude said, being with an experienced hand therapist is awesome. I know for me, my mentor, I'm still very close friends with her, and she has her own practice here in Decatur, Georgia. So I think that's great. And I know from her, there's been at least 5 or 6 different individuals that have become CHTs just from being around her. So I think outside of that, you have to be willing to put the time in. I think someone had mentioned in the chat about the purple book. So for those who don't know what it looks like, this is the purple book, and this is not the latest edition. I think they're on a 4th edition now. So for me, using the purple book was very important because again,
Harold, you're breaking up.
Lost you, Harold. Lost you, bro.
All right, let's go to Chris and then, okay, Harold, you back?
Yeah. But that's what I did. So Chris can go next.
Okay.
Well, I'm usually the first one to want to jump out and talk. I wanted to go last on this segment because understand that number one, this isn't a test that you can just hop out and say, all right, after studying for a month or 2, I'm going to take it. This test takes a good year of studying. My tip to everyone would be, don't be afraid of failure. I'm going to step out on a limb. I've never failed anything in my life until I took this exam, and I failed. It is a very humbling moment. I still keep the letter that I failed in my purple study book because I needed that. I needed that humbling experience. Don't be afraid to fail. I think 33% of people pass it the first time. Don't be afraid. It's a scary test. But if you do get knocked down, get back on the horse and ride again. Another thing, to me, the black book by SHT was a lot more beneficial than the purple book. I had all 4 books because the blue and orange book that Harold put up it's 2 books. I had all 4 of them, but nothing, in my opinion, helped me better than the black book put out by ASHT.
All right. With that said, we have a few minutes for some question and answers. I'm going to let my fellow brothers who are in the chat kind of moderate who should speak. Just please unmute yourself and present your question to the panel.
Okay, just bringing up some questions that were mentioned in the chat from Miss Jacqueline Diggs. We had a question that she's asked, how can we get more African-American interested in the field? And she followed up by saying, we need more practitioners that look like us. So I would address that to the group.
I think we kind of talked about that kind of a bit in the sense of, I think we all owe it. If we want to see more of us, we have to go back to our schools and, get on some guest lecture search, and let them see us and talk about. I've done this a few times, getting out there to schools. And then when you go out, don't be afraid to take on students. Now, the only stipulation I gave is I would not take, for field work, I would not take them on their first rotation. It had to be on their second. But those are the kind of steps that I took to kind of like put out there, when I was trying to, really push and show that we're here. But yeah, we have to get out there. We have to have more discussions like this. We have to, go back to our schools and, go to other schools and show that we're here. But I said that this is a tough road in a sense. And going back to the exam, like, Chris said, like when I left that exam, I was like, man, I'm for sure I'm taking this again. This was like, I tell you, if I have to take this exam again, I would not be a CHD. I'm not taking that exam again in life. That exam was brutal. And like Chris has said, that ASHT book was tremendously helpful. I bought every single book anybody recommended, and I read them all. But, depends on how you learn or how you read things. Certain things are going to be, you got to see what sticks for you. But yeah, we have to get out there and show who we are.
I froze up, brother. So I'm not exactly sure everything Eric said, but one thing I will say is, once again, let's go back to some of our HBCUs where we're rooted at, where we know we can reach out to our Black students, and we'll try to reach them better. As far as taking students, I want a level 2 field work, but when I get level 2 field work, I want that student to want to do hand therapy. If you don't want to do hand therapy, if it's not something you're interested in, don't try to go into those areas, because those areas are deep and those practitioners enjoy what they do. And if we have a student, it's not to babysit, it's to teach. And so if you want to be a hand therapist and this is something you aspire to, reach out to these guys, these members of this panel, other CHTs, and try to learn. It doesn't be just us. You can reach out, try to learn the best that you can.
All right. In the nature of time, we're going to move a little bit ahead, but we will leave. I think the panelists will still be on after the call. Will you have a few minutes after the call to potentially take any questions from the audience members, if that's okay?
That's fine.
So what we'll do is we'll kind of go through the formalities of closing this. And then, of course, if you have any questions, we'll remain on the line. So with that said, the steering committee of the Brothers Organization, I'd like to thank all of them for their hard work on this process. But today is not really about us. We just wanted to show that, but we want to really thank each one of you for coming to this panel. The panelists, you're esteemed. Thank you for your time, your knowledge, your experience, and just sharing that with us today. It's giving us a little snippet. I know just from the conversation, we could have gone on for hours and hours, can clearly see that. But really, your expertise is appreciated. We cannot thank you enough for coming out today to share with the community in regards to what you do every day. And we really appreciate that. With that said, there is a survey that will be provided inside of the chat that you please, everyone, if you can, fill it out and provide us with some feedback. It's always good to hear about how overall you thought this experience was with our esteemed panel. As I said, we cannot thank you again. With that said, these are the references, and at this point, we can adjourn the meeting. The panelists will remain on the call to take some more Q&A questions. Thank you so much for the overtime, gentlemen, and everyone have a great rest of your day.
Thank you all for coming.
Just letting you all know, that the survey link is in this handout that was just shared. We'll share again in a minute.
We can go back to the questions. If anyone has a question, I think Sherry Bryant has her hand up. Feel free to unmute and ask the panelists any questions you have.
So I just have a comment. So as you all saw, well, I am a seasoned OT, graduated from Tuskegee several years ago. That's right, you know. And so I just have a comment. I remember early on when I was like part of the local state association here, and we had a lobbyist to lobby for us for the state of Maryland for certain issues. And so I think as part, when I asked the question about third-party payers, and I think it was you, Chris, that said that they know. And yeah, they know. But we had a lobbyist that kind of lobbied Congress on our behalf, right? And then when you mentioned that, because I don't work in the clinical part anymore, I do school-based. But I remember when they had that Medicare reform, and you're right, OT had the full benefit, and PT, speech and PT had to share because AOTA lobbied on our behalf. So my question is to bring more recognition to you all in this particular sector of our profession. We probably, each one of these states need to probably do some lobbying to their particular congressperson to get more benefit from OT as far as reimbursement. Now, also too, I had a job injury a couple of years ago. And so I was going to physical therapy. And while I was in there, I was observing a few things. And what I observed was that when it came to the hand piece, the PT may have done the assessment, the cursory assessment, but it was the PTAs that was actually doing the therapy. So they're watering down what you all doing. So what you all are doing. So in addition to the education, with all going to different high schools and stuff like that, I think the lobbying needs to be a part of this too. I just wanted to make that comment.
Okay, next question. I think Justin, you're on. Feel free to unmute yourself and ask the panel.
Yeah, good morning, everybody. Thank you guys for having this meeting with us. This was great. So my name is Justin Octave. I go to Tuskegee University. I'm a OT student, and I have an idea for the practice. I box, and so I started boxing before I really got into OT. But when I started, studying and reading more on like the just completing certain ADLs, I realized that a lot of that stuff is the same movements involved with boxing. And so I wanted to kind of add that into the OT world. I wanted to know about how did you guys go about on the business aspect for you guys' organization?
Justin, really quick, great to hear another Tuskegean. Also with the boxing, I appreciate your vigor, but and it's something that you could really look into. But I have a couple of boxers, I have a couple of MMA fighters that I do that for, and it is very, very. We do. So something that you're hitting the nail on, something we can get into. And as far as how do we go about it, man, you just have to put in the work. You need a credential behind your name, as Dr. said earlier, so that people will take you serious. Because so often they won't take you serious if you're not a certified hand therapist. If you don't have those 3 letters behind your name, a lot of doctors won't take you serious. And so that's where it starts. You got to put that work in to get that certification first.
Okay.
All right.
Thank you.
Next up, I believe Angela Reddy, I believe.
Hey, good afternoon, everybody. I am a OTCHT. I've been a CHT for the last 7 years. I wanted to ask, is there a way for us to get a list started of all Black CHTs? I meet people, one here, one there, but I don't really know where we find like a critical mass, so that when we're looking for works, that we can actually help place students either through our alma maters. I went to Hampton undergrad, but I did go to a small liberal arts college for OT school, and they didn't know where hand therapists were to do the field work. So is it possible for us to create a list, or is it somewhere other people already know where that list is?
That's a good question, Angela. I mean, you could create like a listserv or something along those lines. I mean, because it was hard enough after all these years just to find these 4, for us to all get together. And it wasn't until I actually got on LinkedIn that I found another brother who owns his own practice out of Houston or somewhere in Texas, you know, and they have 4 or 5 clinics. So I think it's definitely something that is possible and well needed, because I only know of I know 2 female CHTs here in Atlanta, but that's it. Yeah, it's kind of like if you're not in those circles, if you're not going to continuing education, then your chances of actually meeting one of us is definitely a lot less. So I think when you do meet someone, keep their name, so you're adding to the list yourself, right? So now, like, I have their names. I have people that everyone who I've met on LinkedIn, or I've seen them on Facebook. I keep the count of their names, right? Because I know already that it's gonna be hard. It's hard finding It's hard finding us.
Right. And as we do that, we can also, especially with, I think, some of the members on the panel being so close with with Tuskegee and Howard, just for 2 schools, we can take this information and we can hand it to these program directors and say, hey, listen, these are CHTs we know. These are CHTs that are in this area. And so that will just open the door for more students to come in contact with us. But we, like you said, we have to do our part. And we can just start by making our list here today with the people we know, and then just slowly expanding on the list and getting it to our professors so they can see that where these students that want to go into hand therapy can find someone that looks like them. Because I think out of the 4 people on the panel today, that's 4 different states.
Yeah, I second that, Chris. I think being able to just start here today, we already have 4 of us here, and I'm sure a lot more people in the audience interested. So if we could start a list today and then continue to build on it, I think it's a start, because I don't think I've ever come across a list like that, but it definitely is needed. And I think, why not start today?
All right. Thank you so much, Angela, for your question. Alan, Pierre, you can unmute yourself.
Good morning. Just making sure you guys can hear me.
We can hear you.
Okay, good. Yeah, so actually, I'm calling from California. I woke up early for this presentation. I felt it was worth, losing a couple of hours of sleep. I just wanted to acknowledge, first of all, I wanted to acknowledge one of the my first mentors, who is a black female CHT, and she was actually one of the OGs. She received her certification, I think, in '92 or '93. There's not many of there wasn't many of us back then, but it seems the more I interact with other OTs, I keep discovering Black CHTs a little bit everywhere on social media or at work, and it seems like we're not so much the magic unicorn that I thought we were. So that's a good thing. I guess my question is for Dr. Eric. I want to put some respect on your name, so I want to make sure I pronounce it right.
Dr. Spites.
Dr. Spite.
Spate.
Oh,
Dr. Spate.
Oh.
My apologies. I did it again. Trust me. I apologize, Eric.
So first of all, thank you for your service. I'm actually interested in joining the Air Force next year, and I've been told that they really favor people with hand therapy experience. If you had a little bit of, what is your experience working as a hand therapist in the Air Force? What are some of the more interesting cases you've seen in that field?
Great question. It is probably, I'm telling you, because before I came in, I practiced, in a private setting, and coming to the military, I'm telling you, there's no other practice. I don't think I could ever practice on the civilian side again. Y'all have too many limitations. I can make referrals. I can see direct access. I have access to tons of modalities. I can order X-rays. I can order MRIs. I get those read and back to me. I can do referrals to ortho. It's just so many benefits that I just don't have in the civilian sector. I think that you're limited as a therapist to me. So you guys are the heroes on the civilian side, because to do what you do, having to wait for some of the stuff and the limitations that you have to practice under is just enormous. And coming from that side, I know what those limitations are. So I can do a lot of things that you guys don't have the privilege to do. So having the privilege to be able to do some of the things that I do in the military side is amazing. Now, the injuries, I've seen everything. So I know you guys have seen the movie 13 Hours, where that Benghazi, the whole thing about the Benghazi thing and the special operatives and all that kind of stuff. I treated one of the guys that got injured in that when I was stationed out in Colorado. I've had, guys that fell off of tanks during deployments. I've had some very interesting injuries that you're just not going to see on the civilian side. So my practice in the military has been amazing. I wouldn't trade it for anything. And yeah, if you ever get the chance to serve, and it doesn't matter if it's Air Force, Army, or Navy, as an OT, we're a little bit more limited on the Air Force side. We're primarily in hand and upper extremity. Some of us have delved in some of the other, tried to get as almost like side jobs, in a sense of getting into mental health stuff and some of the other stuff. I do some sleep stuff. I do a lot of different groups with different things, but mostly it's hand and upper extremity stuff that we do in the Air Force. But in the Army has they use their OTs a little more extensively. in other areas, and the Navy to some degree. But if you want a more diversity in your practice, it's probably going to be the Army. If you only want to do hands right now, that's where we're limited to. In the Air Force is mostly hand practice. So, and you have to have that experience because we only take a small number in each year. If you wanted to practice in the Air Force, you have to have that hand. And to give your upper edge, you would have had to have some experience like in a VA or in any type of military setting.
I have about 4 or 5 years experience with hand therapy, and I have seen some VA patients.
No. I'm saying actually practicing in a VA or like at a military treatment facility, military hospital or something like that.
Okay.
Because there's a lot of contract gigs. People will go and work. They'll put out contracts every now and then. You'll see we have some contractors that work for us now, and I know the Army does and the Navy does as well. So on some of the bases in the hospitals on the bases. But they also, again, they have civilians, but they're civilian jobs as well, not just contract. They're civilian GS working in some of those as well. So I'm not saying that you can't get in. I'm just saying if they're only taking in a small number of people per year. So let's just say if we take in like 2 people per year, and could be 50 applicants. So they're going to narrow it down to the ones who have the hand and upper extremity, and then narrow it down any further to the ones who have that military working in a military environment experience. Those are going to be the top candidates just right off the bat. That's just how it goes. So that's what I say. If you're really interested so in the interview, because there's an interview portion, if you can bring out that military experience and you understand that patient population, because it's a different patient population, understanding all of the aspects of returning to duty and that sort of stuff, you don't have a whole lot of you have to understand that if you can speak to that knowledge is going to give you an advantage. That's just what I mean. Not to say, so if your whole candidate pool, none of you have military experience, then, it's just based on your experience and how you interview. Does that make sense?
Yeah. Thank you very much, Major. I'll let Andrew finish your name for me.
Okay. All right, Delvin,
Let me chime in real quick. Andre, I saw you put Johnny Barthel in the chat. Johnny Barthel was my mentor. He was my fieldwork supervisor.
All right.
If you are in Florida and you get the opportunity to work with Johnny Barthel, do not miss it. He's a great fieldwork educator. He's a great friend of mine now, and he takes that job seriously, and he will take care of you. He will make sure you will not leave his office not understanding him.
Chris, I was academic field coordinator in Jacksonville, and I couldn't agree more. Johnny, great therapist, and he nurtured OTAs and OTs into working in orthopedics. So, big time.
Johnny is amazing.
Delvin, you had your hand up?
Yes, I just got some information that I want to yield time to Dr. Phyllis Ross, who I understand is now serving on the American Society of Hand Therapy Diversity Committee. So Dr. Ross, you can go before me. Howard University.
Yes, first of all, I want to say thank you very much. This has been totally awesome. And full disclaimer, brothers, I came to support Claude. Claude was one of my students at Howard. He came and worked with us in our clinic. So I'm here for Claude, but Dr. Banks has put me on the spot, and it's very important for me to say that the American Society of Hand Therapy does have a diversity, equity, and inclusion committee that has just basically jumped off. And I was very fortunate to be included on that committee. So I think that this is wonderful. Rachel Piggott, who has done a number of articles for the Journal of Hand Therapy. So if you have interest in lymphedema therapy, that's mostly where her work is. But she is very authentic and wanting to do something, wanting to be inclusive. So I think that this is wonderful. I am available. So Delvin knows how to get a hold of me. Again, I think that this is awesome. And I think that if each one of us will teach one, then we will grow. And this has been wonderful. I've been kind of, chatting with Dr. Spate and Claude a little bit, Chris and Harold. Thank you all. Thank you so much. This has just been wonderful. I've even been talking to Dr. Banks about how we can actually at the university expand what you all are doing, because I think there's so many young people who are interested, and the more that we do this and the more that we expand, I think the better we're going to be. We have to, just kind of like back in the old days, if we want it done, we're going to have to do it ourselves. That's all I want to say about that. But Delvin, thank you very much for acknowledging the fact that that committee does exist. And I will be in touch with the brothers so that I can make sure that I share information as it evolves. Okay. And if you guys get a survey, please fill it out. It's very important because they're looking at it very closely. So let us take heed while we can. But thank you so much again, each of you. And Andre, good to see you.
Good to see you, Dr. Ross. Have a great one.
Ross.
Thanks, Dr. Ross.
All right.
All right. Do we have any more hands?
So before I pass it on to Dr. Ross, what I wanted to say was kind of what she said. I was trying to see how the brothers could pipeline this into another idea. And when I was thinking of this, thinking of this vision of this hand therapy session about 6 months ago, back in the spring or summertime, I was looking up folks on LinkedIn, and I found Eric and Harold, and I found Angela. And Angela was like, "Hey, what's up, the ladies?" I said, "Well, we're going to do something in the future." And so, doing the brothers panel, we decided that we may want to do like a podcast style event where we can just have an open conversation about, so it's more informal. We can just have a dialogue. And I think that's where we're going to go with this potentially. So I talked to Dr. Banks and Dr. Phyllis, and we can kind of maybe create like a diversity podcast from this. So we can talk about it more. So including you, Angela. All right, thanks.
All right. Well, in respect to the time of the panelists, they've gone overtime here. Just want to say thank you again coming out here and just providing us with all this knowledge and blessings, simply put. It was great to have you. If there's no one else at this point, I would just like to say,
Andre, Sean chiming in here.
Yeah, Sean,
thank the
go
brothers
for it.
again for coming on. We need some more pictures up so we can take a group picture. We gotta say thank you publicly as well. So gentlemen, we're missing one. And any brothers that are up, please put on your cameras. Let's get a pic.
Okay.
So Dr. Fred, can you just highlight them and highlight yourself as well, please? And spotlight yourself as well. Dr. Fred, yourself too, please. All right. Angela, you're all the way up there, so you got to turn on your camera, or you got to take your hands down. All right, there you go. And Dr. Ross, please as well. All right. You ready? Anyone else want to join in the picture?
Turn your cameras on. Turn your cameras off for 1 minute, guys. Everyone, please turn them on. Turn them on. Turn them on. Turn them on.
All right. I think we got a few.
Not many.
All right. That's it. We'll take what we have. Thank you very much. Hold on. I'll tell you when. 1, 2, 3. Got it. Thank you.
Thank you, Brother Sean.
Thank you all for coming. Thank y'all for having us. And it's been fun.
Been good time. Yeah. Thank you, CHGs.
All right, everybody.